much for be here in this our first clinical case presentation on this February. I am Laura Gochicoa, and I'm going to present what we are going to have today. So the name of this webinar is if there is a plan B for gastroesophageal reflux associated with respiratory symptoms, and what you see is not always the expected. So the group from Turkey is going to present this clinical case, and will be presented by Burcu Kapraz, and then will be discussed by Hassan, Ozgi, Safer, Fonda, and Hudaber. I don't know if I pronounce well, but thank you very much for all of you to be here. And okay, I leave you with Burcu.
Thank you very much, Dr. Rangel. And I am trying to share my slides now.
So, yeah, there you go.
Yes.
You can see, I think, now. Hello, everyone. Again, I'm Burcu, and I'm working at Hacettepe University as pediatric pulmonology resident. And today I will present two pediatric cases who were followed up in Celal Bayar University in Manisa. And as you said, Professor Yilmaz from Celal Bayar University, Professor Dokuncu, Professor Çetin, and Professor Afer are from Ege University, and they will join us as discussers for these two cases. And first of all, before starting the presentation, I would like to express my special thanks to ATS committee and Dr. Özge Yılmaz and Dr. Laura Gochicoa too, and to Enrico Lombardi also. And I should say for case one, there is a plan B for gastroesophageal reflux associated respiratory symptoms. Our first case is a 4.5-year-old boy with a history of recurrent croup. His mother's first pregnancy, he was born at 37 weeks with a normal Apgar score. His birth weight was 3.2 kilograms. He was hospitalized on the third day after birth due to hip hyperbilirubinemia and discharged after 2 days of hospitalization. No other abnormalities were detected in the neonatal period. When we look to the past medical history, at the age of 2 years, he underwent PDA closure surgery and was still being followed up by pediatric cardiology due to aortic stenosis. His mother reported normal physical and neurological development, and he was fully vaccinated. He had no history of allergies, no atopy, no ARC symptoms. He had a feeding history before going to sleep at night. And in another center, before admission to Celal Bayar University, he had been started on inhaler corticosteroids, and lansoprazole treatment had added to his treatment when his complaints did not improve. When we look to the family history, no consanguinity between parents, no family history of respiratory disease, and his father had urticaria. At the time of admission to Celal Bayar University Hospital, his main complaint was recurrent croup for 1 year and cold that did not change during the day. His physical examination demonstrates that both weight and height falling between the 15th and 75th percentiles. His vital signs are pretty much normal. Both lungs participate equally in breathing. There was no rales, no bronchus, or wheezes, and he had a systolic murmur of grade 2. Now I would like to give the floor to Professor Yilmaz from Pediatric Allergy and Immunology Department for differential diagnosis of recurrent croup.
Thank you, Burcu, for the nice introduction. Well, recurrent croup is a symptom that we see frequently in children because airway inflammation and edema may lead to laryngeal narrowing. And if this condition happens more than 2 times a year, then we call it recurrent. It might be viral, it might be due to viral etiologies or plasmatic, and the incidence of recurrent croup in this age group is 5%. Why do we see it in children more? Because children's, the diameter of the airway in children is small, so 1 centimeter edema would lead to about 75% decrease in the airway. Thanks, Pooja. There are many reasons for recurrent croup. What we need to decide on is if there is an anatomic abnormality or if this is a functional thing, because that either it's anatomic or functional, that defines how we approach these children. Yes, thank you. So when a child comes in with recurrent croup, we try to decide if there's a suspicion for airway anomaly. That is determined by, like, if the child is less than 3 years of age, if there's a prior history of intubation, or if the child required hospital admissions for croup, then the suspicion for a possible airway anomaly increases. So for these children, even when we first see them, we can just proceed to laryngoscopy, bronchoscopy, and or endoscopy. As a result of this, either we define a specific cause and treat for that, or if there's no anomaly, we do episodic treatment and follow-up. Well, if we don't have a suspicion for airway anomaly in a child that comes in with recurrent croup, then we ask for history. And if it's not specific, or if you think of asthma, then we might start an ICS, inhaled corticosteroids, for 12 months. And if there is an in-between croup, then we start on proton pump inhibitors. If there are still recurrence of the croup episodes, then it has to go to further investigation with laryngoscopy, bronchoscopy, and endoscopy. If the history is significant for gastroesophageal reflux disease, like recurrent abdominal pains, vomiting, swallowing during night, or attacks that start suddenly during the night while the child is sleeping, then we can immediately start 8 weeks treatment for gastroesophageal reflux. But still, if the recurrence of croups are going on, then we need to go for further investigations. Thank you. For this child, since he had history of vascular anomaly, cardiovascular anomaly, we had a high suspicion for anatomic abnormality and actually vascular compression of the airway. Literature says that frequency of gastroesophageal reflux in children with recurrent croup varies from 5% to 80%. While this wide range in different literature is mostly due to a wide range of subjects enrolled. Thank you. Okay. However, most studies have shown that in all the studies, more than 50% improvement was detected with gastroesophageal reflux in children with recurrent croup. Thanks, Butcher. I think that's
Thank you very much.
Okay,
thank you. Our patients' complete blood count and clinical biochemistry analysis values were in the normal range, and immunoglobulin level for normal for agents with sweet chloride test was also normal. And he had specific immunoglobulin E antibodies to REST panel, wood panel, and alive. And respiratory viral panel testing identified respiratory syncytial virus at the time of admission. Respiratory a positive skin prick test was detected also, as you can see on the slide. Now I would like to give the floor to Professor Apaj from Pediatric Radiology Department for all radiological image interpretations of the patient. Thank you.
Thank you very much. Good evening, everybody. In the AP chest radiograph, we see a very prominent pulmonary artery. Otherwise, the chest X-ray is, well, it's not very well exposed, but it's uneventful. I can't see any consolidations or any obscuration of contours or anything. The trachea is in the middle, and mediastinum is, well, as it should be. The lateral radiograph is underexposed, and it's very hard to tell anything from this radiograph at this window. Can we change the slide? Okay. I don't know if the, can I, okay. What I see is, can you stop, please? Okay, what I see is a large, very large aorta with enlargement of the common carotid artery on the right. And the left chambers are enlarged. I can see, yeah, here, can we stop in the back? The aortic arc, ascending aorta is very large. Pulmonary artery is very large also. And we see at this level an obturator at the level of the ductus arteriosus. It's not very clear in this window, but we can, well, I have seen the images beforehand. And if we move on the lung windows on the right, yeah. We can see the vessels as well in this window also. We see very large aortic arc and a very large pulmonary artery, which was evident on the chest x-rays. At this level or below this level, we don't see a very clear narrowing of the airway. But as we go down at the basal parts of the lungs, we see consolidation, small acinar consolidations at the right middle lobe, medial segment, left lower lobe, and the lingular segment, lower lingular segment, which is indicative of aspiration, chronic aspiration. We don't see a clear narrowing of the airway or the esophagus. Okay, can we go on to any other images which we have? The coronal view also displays very large aorta, very large right common carotid artery, as well as a very prominent pulmonary knob, pulmonary artery. But otherwise, we don't see anything more. And the sagittal view, in the sagittal view, yeah, we see some narrowing at the level of the aortic isthmus, which is at the level of the ductus arteriosus, which is obscured by an obturator. But this could be something like patent ductus arteriosus or combined with aortic valve disease, stenosis of the aortic valve, because the ascending aorta is very large. But still, we don't see any narrowing in the airway, nor there's any narrowing in the esophagus. These are upright esophagograms, and then there's some. The next views are these are uneventful. The next views I've seen, these are supine gastrointestinal series, and if there's any reflux, we should see them here. Okay.
Thank you.
I don't see any reflux at these two projections.
Thank you, Professor Yilmaz. And now let's examine the flexible fiber optic bronchoscopy video. Here we start. Now we will see a pulsating compression between 2 and 4 o'clock levels, 3 cm proximal to the main carina. We will see also an elbow-shaped compression and pulsation in the left main bronchus. And also white-colored secretion increase was observed in the Soleil rays too. We will see. Echocardiographic evolution of the patient showed mild aortic stenosis and mild aortic insufficiency also. Bronchial lavage fluid samples culture results were negative, and also no pathology was detected in the bronchial lavage fluid samples. During hospitalization, IV dexamethasone, inhaler adrenaline and steroids, ipratropium, and salbutamol and oral antibiotic treatments were initiated. Dexamethasone was discontinued on the 3rd day of hospitalization. Anti-reflux therapy was added to the treatment process. After bronchoscopy, thorax CT and thorax CT results, he was referred to the cardiovascular surgery department of Ege University School of Medicine. Since the vascular compression was not very pronounced, surgery was not planned in the first place. It was suggested that the aorta was wide. It could be followed up for 6 months with ACE inhibitor. Also, for the evolution of Marfan syndrome, Ehlers-Danlos syndrome, genetic study was planned. He was discharged with inhaler steroid therapy and anti-reflux therapy. About 3 months after discharge, he was hospitalized four more times. In April, treatment was changed to losartan due to the side effects occurred after discussion at the cardiology council. And then baclofen treatment was started with recommendation of pediatric gastroenterology due to the persistence of the patient's findings. Now I would like to give the floor to Professor Çetin from Pediatric Gastroenterology Department.
Good evening. It's my pleasure to meet you tonight. This was a very good case, and when he was admitted to us for the non-responsive reflux disease, we have decided if the complaints were due to reflux or not. But our guidelines that was documented in 2080 by ESPGHAN and NASPGHAN defines that if there is chronic cough, I mean the presentation of airway more than 12 months, may be decided as reflux disease. So we decide if he had the proper treatment for reflux disease. He had 8 weeks, that's Sakharov for us, of PPI treatment, and he was unresponsive to treatment. So what we had to do, we had to make an endoscopy for underlying mucosal disease or something else. I mean the erosive esophagitis or non-erosive esophagitis for reflux disease. And we have to perform manometry combined with impedance studies. But he was 4.5 years old. And in this age, it's very hard to of the patient to cope with manometry. So we could have done impedance study, but the pediatric impedance catheters have eyes 5 centimeters away. And if the esophagus length is low, so 3 or 4 eyes will see the impedance falls. So we have decided this patient has a narrowing of the airway and a pulsation of the esophagus. It may be the vomiting, there is no dysphagia, and there is no risk of esophagitis, eosinophilic esophagitis. So we have decided to use a trial of baclofen. For what reason? Baclofen is a GABA receptor agonist, and it mainly relaxes the muscles and transient lower esophageal relaxations, and makes the stomach go down. So I mean the emptying of the stomach. So for this patient, especially when we think about anatomical defect as well, we have tried baclofen at a dose of 0.5 per kilos, and after the first week, we have evaluated the patient. The mother exactly says that at the 3rd day of baclofen, the cough has gone off. What about the side effects of baclofen? There isn't a data of the pediatric side effects of baclofen because the data comes from the adult series. We have experience with baclofen, especially in patients with esophageal atresia. And what are the side effects of baclofen? Is dizziness, drowsiness, dyspeptic symptoms, and fatigue. This patient had experienced dizziness for 3 days, but we have lowered the dose, and after a period, dizziness has gone off. And I think what will Burcu and Özge say, I don't know, but he is going well with baclofen. But we have, if the patient grows, maybe 1 or 2 years later, we have to document how the muscle works there and what is the impedance. I must say as well, for the impedance studies, there's not a cut of number that reflects, that defines the reflux in children. In adults, an impedance fall of more than 4% is called reflux disease. But there, as you can decide, there isn't studies for the normal values of the impedance values attributed to age of the child. So we have to read very well in the impedance trace. In adult series, in pediatric cases, reflux is divided to non-erosive refluxes, reflux hypersensitivity, and functional heartburn. But in adults, there is also one more type. It's called the clearance defects. So in children as well, the function of the esophageal muscles also can cause to clearance defects. We had also decided in this patient It may be due to clearance defects. It may be the reason why the baclofen has worked in this patient. Thank you very much.
Thank you very much, Professor Chetin. And I will continue to the presentation. We wanted to add this illusion feature to the presentation both for the case 1 due to the findings of compression on the trachea. As you see the sphere here, it has a compression to trachea. And also for the case 2, because of the diagnosis that you will be surprised by. So what you see is not always the expected. Our second case is 8-year-old boy with a history of persistent wet cough. He was born at term. He had no history of neonatal intensive care unit hospitalization. He was fully vaccinated, no consanguinity between parents. He has a sibling diagnosed with phenylketonuria, and he has no additional features. When we look to the past medical history, he was admitted to Behçet Children's Hospital due to wet cough for 5 months and fever for 1 week, then followed up with a preliminary diagnosis of lower pneumonia and atelectasis in pediatric infectious disease inpatient clinic for 1 week. After 1 week of persistent cough symptom, he referred to Manisa Delaware University Pediatric Pulmonology Department for bronchoscopy due to a preliminary diagnosis of foreign body aspiration. When we look to the physical examination, weight and height of the boy were normal, and he had diminished breath sounds in the right basal area of the lungs. He had no chest recession and no added breath sound. And now I would like to give the floor to Professor Yüksel from Pediatric Pulmonology Department for differential diagnosis.
Thank you, Burcu, for your excellent presentation of cases. And we want to differentiate the problem of the cases for 5 subunit. One of the pneumonia, foreign body aspiration, extraluminal compression, interluminal pathology, and also a tumor in interluminal masses. But if we want to differentiate the pneumonia is possible in this patient, but because he had fever from 1 week, however, pneumonia will not explain symptoms for 5 months of cases. And also second, foreign body aspiration is not likely since the child is 8 years old and he doesn't report aspiration also. And the third is the extraluminal expiration, but the extraluminal expiration due to the acute lesions such as lymphadenopathy or mediastinal mass is possible. Therefore, imaging of the bronchoscopy were planned, and you can see following slides of Burcu. And also, last is the similarly interluminal pathology are possible such as neoplasm, and were planned to be the rule out with imaging and bronchoscopy. And then the Burcu will explain and also present the differential diagnosis subunits. Thank you, Burcu.
Thank you. Complete blood counts and biochemistry analysis levels were in the normal range, and immunoglobulin levels were normal for age 2. Now I would like to give the floor to Professor Alper again from the Pediatric Radiology Department for the radiological interpretation of the patient.
Thank you very much. The left-sided posterior anterior chest X-ray is very informative. The right lung has diminished in size compared to the left side. The contours of the right diaphragm and the right atrium is obscured, indicative of right middle lobe and right lower lobe atelectasis. If we take a look at closer look, we can see the trachea, the right main bronchus and the right upper lobe bronchus, but we only see part of the intermediate bronchus. Some part is obscured by something. This could be any intraluminal pathology. At this stage, we cannot differentiate anything but intraluminal pathology. The lateral radiograph reveals the normal left diaphragm. Some part of the right diaphragm is seen, but the rest of the right diaphragm is not evident on the radiograph. So it's right intermediate bronchus obstruction. Thank you. The mediastinal view is very fast, of course. At this stage, we see narrowing of the right main bronchus or right intermediate bronchus. It's open now, and what we see is loss of volume in the left lower lobe and now in the right lower lobe. But if we take a look at the right side, let's go to the lung window. Yeah. In the right window, it's very easy to see the obstruction in the intermediate bronchus. It's narrowed, it's obscured. And then if we go down, we don't see the bronchus. Now it's open. And we see loss of volume in the left lower lobe, the major fissure, and the right middle lobe. And all what's occupied in what's aerated in the right hemithorax is the upper lobe. Obstruction in the intermediate bronchus.
Thank you, Professor. When we look to the flexible fiber optic bronchoscopy, now we will see it here. When the right main bronchus was entered with FFB, it was observed that the right upper lobe was normal but slightly downward and to the left compared to the normal position, and the entrance to the intermediate bronchus was completely closed by the mesh structure. The mesh was observed to be moderately vascularized with a mild mucoid secretion. There was no bleeding, no degenerative features in the appearance of the mesh, and the left main bronchus and distal areas were completely normal. There was no bleeding, no additional problems during the procedure. And after bronchoscopy findings, patient was referred to and operated by pediatric surgery at Ege University School of Medicine. Now, I would like to give the floor to Professor Dökümcü from Pediatric Surgery Department to discuss the patient's surgery. I'm closing the slides.
Okay. I would like to express my gratitude to the chair and Professor Hasan Yüksel and Burcu. It was a wonderful presentation of the case. I would just like to remember the CT images. The mesh on the CT and the flexible bronchoscopy was located in the beginning of the intermediate bronchus, as you can see on the downline at the very low side. And the lesion in the rigid bronchoscopy was originating from the anterior medial aspect of the intermediate bronchus. The cranial side was around the upper lobe bronchus, but we could not see the lower edge and the relationship between the lower lobe and the middle lobe bronchus. So we had to either take a biopsy to show the pathology, and also we wanted to see the lower border of the lesion so that we can plan the surgery. It suggested a carcinoid tumor, and the pathology was confirmed the diagnosis. And as you can see in the image in the middle, the lesion started at the level of upper lobe bronchus. You can see the entrance of the upper lobe on the right, and at the very right in the bottom line, the lesion was nearly ½ centimeter away from the middle and the lower bronchus entrances. So we have to make a decision and a strategy. You are somehow not very lucky, or maybe lucky, to fight against signs and symptoms, and we fight against physical enemies as lesions. But believe me, it's not very easy in every case, and this is one of the most challenging cases we've ever encountered. So these are the options that we could do. You see the lesion in the beginning of the intermediate bronchus. So the best option was to take out the intermediate bronchus, leaving all 3 lobes in its place, a lung preservation surgery. This is the best choice. But of course, if it's the best, it is the hardest. And when you think about the anatomy, the bronchus is at the very posterior in the hilum, and there are always venous and arterial branches over it. So without sacrificing any lung, it's very hard to get to the exposure of the intermediate bronchus. So we definitely could not do the best option. So we switched to the second one. It is much more easier and also wiser to do an upper lobe lobectomy and resect the intermediate bronchus, and then make an anastomosis to the intermediate lower pole of the intermediate bronchus to the main stem. But when you are doing the upper lobe lobectomy, the arterial supply of the upper lobe is some way cranial to the lesion. So even if we did the lobectomy, there was a chance that we could not see the border, the lower border of the lesion. So we have chosen and also a middle lobectomy. The other options were not preserving the middle and the lower, taking them both, keeping the upper lobe. This was the easiest, and maybe if you ask the pediatric surgeons all around, 80 or 90% would do this one. But and also pneumonectomy is always an option, but we try to preserve lungs, as you all know. So we did this. The lesion was excised with another wedge biopsy. The middle lobe was resected. The lower lobe was incised and then anastomosed to the beginning of the main stem. So these are the operative figures, this was video-assisted thoracoscopic surgery, even with a little incision, a mini thoracotomy incision, and a video-assisted surgery, which makes it much more comfortable and much more faster healing, and also a great exposure, as you can see. Of course, this child was a challenging one, and the major fissure and the minor fissure was incomplete. So first we had to separate the upper lobe, which you see is on the left, and the middle lobe, which you see on the right, and the lower lobe is at the bottom. We have to separate them first, and you see the pulmonary arteries of the upper and the lower lobes. And then you see the stitch around the lower lobe, and the middle lobe is on the right, and the upper lobe is up on the left corner. And here, while the pulmonary artery of the lower lobe is preserved, we have incised the lower lobe bronchus, and then taken out the intermediate bronchus. The left arrow is the lower lobe entrance, and the right upper arrow is the upper lobe, also the main stem side, and the bottom is the middle lobe, which we have done the middle lobectomy. And when we incised the cranial border of the lesion, we saw that the anterior, which you can see here, the anterior medial aspect was still with lesions, suggesting a wedge resection, and also we made a further wedge resection, and the frozen section was okay with the surgical borders without lesion. And then we have completed the surgery with the lower lobe bronchus anastomosis to the main stem bronchus. And also we did an intraoperative flexible bronchoscopy. You see the wedge resection repair on the upper part, and you see the entrance of the upper lobe at the bottom, and the lower lobe in the middle. It is open, it's not obscured at the very first postoperative period. The first postoperative X-ray was quite better than expected, because we expected the edema and some bleeding and some obstruction, whereas we had a moderate suggesting obstruction. I wonder Professor Alper's opinion also for these X-rays. And then in the postoperative second week, the airway started to open again, and we are planning to do a control flexible bronchoscopy at about 4th or 6th week. So thank you for listening. I hope it's not too much surgical.
This was what.
Okay. And okay.
Okay, can I continue? You want a floor or okay, I can continue. And the patient pathology, as you said, was resulted as carcinoma tumor. And I would like to finish my presentation by briefly talking about carcinoma tumors in children. Variety of carcinoid tumors are the most common primary malignant lung tumors in children, comprising between 63 to 80% of all cases. These tumors arise from bronchial mucosal neuroendocrine cells, which have the ability to secrete amines and peptides. Children typically present with respiratory symptoms, including cold, chest pain, wheezing, hemoptysis, and difficulty in breathing. Misdiagnosis as asthma is common given the nonspecific and persistent respiratory symptoms. Endobronchial obstruction by the tumor can lead to a unilateral lobar consolidation on chest radiograph, commonly interpreted as pneumonia. The presence of a tumor may only become apparent after investigations for these recurrent episodes. Rarely, children can present carcinoid syndrome caused by the release of systemic vasoactive substances that cause symptoms including wheezing, flushing, palpitation, and diarrhea. Is rare in the absence of metastasis. Bronchial carcinosis is usually detected as a mass of chest imaging performed for respiratory symptoms. Diagnosis is generally confirmed by histopathological examination following endobronchial biopsy. Bronchial carcinoids are further subdivided based on malignancy potential, with a majority of pediatric patients presenting with typical carcinoids which have low malignant potential. Atypical carcinoids are less common in pediatric population and have an intermediate malignant potential. For localized tumors, a complete surgical resection is the treatment of choice. Lymph node resection is recommended for atypical carcinoids given its increased malignant potential, and recent data from the National Cancer Database showed the 5-year overall survival of 95%. Thank you for your attention.
Thank you very much for you. Well, this is an amazing clinical case. It's very rare to have this cancer from the lung, no, in children. So, well, there are a lot of congratulations in the chat. I don't know if somebody wants to add something. I just have one question. Well, I don't know if it is for Dr. Schaefer or who. It could be appropriate in these cases that during the bronchoscopy can take like a biopsy when we see those kind of lesions, or it's better to leave it like that, or what is your comment?
Thank you for the question. Due to the sake of time, I've a bit got faster in the bronchoscopy section. We had to do 2 sessions of rigid bronchoscopy to clear out the lesion with laser, because these lesions tend to bleed. So with the flexible bronchoscopy, I would not be very comfortable, because you can easily lose your image, and also for suction or for even laser or a cryo device have to be ready with you in those cases, because a few millimeters of blood can stop everything. So I think these kind of intraluminal masses should undergo rigid bronchoscopic investigations. That's why I also want to express my gratitude and thanks to Professor Hasan Yüksel, which we work very parallel and think parallel. And I cannot say that one is better, but flexible and rigid is always has to be side by side. So it may be either you doing both, or there must be somebody with you doing the other thing. Thank you for the question.
Great, thank you very much. Okay, so I don't know if somebody wants to add something else, but this was, I think this is the second case I see in my life, like something like this in 20 years. So it's amazing.
Dear Laura, probably I will be seeing it in the next 10 years.
Yes, yes. Well, we all hope we never see this kind of cases. Okay, so there's a lot of congrats in the chat. I don't know, Ozzy, if you want to add something else or invite
One more
everybody for
question.
our night.
There's just one more question from Algedo Hernandez. Do you recommend cryobiopsy for this lesion? I think this is to Zafer again.
I'm sorry, Özge. I think I've been using this stage. Cryotherapy is effective to get rid of the lesion, but with cryo, you will never know the pathology because there will be too much necrosis in this pathological evaluation. And for these kinds of lesions, it's very important to make the diagnosis for the pathologies with mitosis and also necrosis. The cryo is very likely to do the necrosis, so they don't want that really. So if you know the diagnosis, cryo may be an option, but the resection, as Burcu was very well documented, the originating cells are within the bronchus wall. So the resection of the bronchial wall is mandatory to resect totally. The topical excisions will likely to recur at about 15% or so. So
Okay, well, okay, so thank you very much to everybody for being here. Thank you, Miriam, for opening our Zoom. And we invite you for our next clinical case that on March. So pay attention to our messages that you will receive to be there. Thank you, Ozzy. Thank you, everybody. Big hug from Mexico.
Big hug from Turkey.